Welcome, everyone. We are so happy to have you here on a Friday at the start of summer. My name is Dr. Jen Sirico, and I am the incoming chair of the ABCT Parenting and Family SIG. And today we are thrilled to have Dr. Guy Diamond, who is Professor Emeritus at the University of Pennsylvania School of Medicine and was Associate Professor at Drexel University in the College of Nursing and Health Profession until he retired in 2023. At Drexel, he was the director of the Center for Family Intervention Science, and his primary work has been in the area of youth suicide prevention and treatment research. On the prevention side, he has created a program focused on training, screening, and triage to be implemented in non-behavioral health settings. On the treatment side, he is focused on the development and testing of attachment-based family therapy, ABFT, especially for teens struggling with depression and suicide. ABFT has now been applied to children and young adults, LGBTQ plus youth and adults, and adopted in clinics all over the world where it's used as a transdiagnostic approach to patient mental health and ruptures and family attachment. Dr. Diamond is now president of the ABFT International Training Institute, which disseminates this model around the world. So please welcome Dr. Diamond, and I will turn it over to you.
Thank you, and welcome everybody. I always wonder who's she talking about when she says all those things. Quite a mouthful. I do recommend retirement from university for anybody thinking about it. It has been the best move of my life. Still quite productive, doing publishing and teaching, but I just don't have to deal with the IRB anymore, and that's been a real blessing for those that know that experience. And I do want to thank everybody for coming mid-June like this. I know you're probably family graduations happening and family vacations starting. So I'm honored that you guys would take the time to come. What I'm going to assume is that there's a spectrum of family involvement. Jen and I were talking about this, of family involvement in child-focused therapy. I could be work with kids, and my main involvement with parents is payment, coordination, transportation. That's a pretty old school, no, I don't think many of us do that anymore. The old analytic model where you didn't want to threaten the alliance with the kid, so you never talk to the parent. That's the Yale Studies Center used to do that. Hope I'm not, no one's from there, I'm insulting them, but then I think there's a wider spectrum of I'm child focused, I'm helping the kid cope, teaching them coping skills, maybe doing explorative trauma work. And I need the parents to support that work. So I bring them in, I do teach them some skills. And that has a whole spectrum. A number of people might say, here's what we're working on. I'd like you to help with this. And other people might say, I have a 4-week parent education program that I'd like you to participate in. It's a little higher commitment, but I think it would really strengthen your ability to help your kid. So there's a whole range in there, and you think about where you land. On the other extreme are us kooky family therapist types, where the family relationships are the focus of therapy. Less so on the symptom, less so on the child's individual functioning, and more, how does the environmental context of this kid reinforce growth or deterioration? We know families can cause a lot of kids to have mental health problems. Just unfortunate. We all have families like this: divorce, domestic violence, alcoholism, where kids are really feeling thwarted and unsafe in their environment. And that shows up in depression or suicide or acting out. But we also see a lot of families that are really pretty solid and pretty good and stable. But sometimes the disease in a kid, the disorder in a kid, can be quite destabilizing for a parent. I know myself, I had my son develop school phobia in fourth grade, refused the first couple of weeks. We were like going round and round, went to see a psychologist, and my wife and I were both psychologists. And we were almost going to divorce at the end of this. We were at each other's throats. You spoil him. Well, you're too hard on him. And you should have got up in the morning. And so sometimes even, a kid with OCD or schizophrenia, where there's more biologically driven problems, families fall apart in the face of that stress and aren't able to provide the secure base environment that will improve the likelihood of this kid recovering. And family therapy lives more in that zone. Is there problems in the family driving kids' stress? Is the family stressed out because of the kids' problems and not as available to the child as they could be? And what do I need to do to work with the parents, the kids together, maybe the siblings, maybe the grandmother who lives in the apartment in the back of the house, in order to bring the system back into alignment so it provides the sort of cocoon of developmental safety that allows kids to grow and prosper. So you may work in a wide spectrum like that. In some cases, you may be in different spots on that spectrum. I'm going to talk today a little bit about if you were going to do a more family-focused work, what would that look like? What might the goals be? How would I try to approach that? How would I engage? Hard enough to get a parent to drop their kid off and pay you sometimes as a level of engagement, let alone, mom. In our world, parents call up and say, I'm dropping Johnny off and I'll pick him up at 3. And we, us family therapists and you family focused people, got to say, mom, why don't you come on in for a little bit? You could help me understand Johnny. Maybe I could help you think about how you could be more helpful to Johnny. And the whole battle of winning them over to the idea of participating in therapy. With adolescents, it's particularly problematic because parents say, well, why should I come? I'm not the problem. And kids say, I don't want to come at all anyway. So you're dealing with engagement with both the teen and the parent at the front end of work, and often as an ongoing process. You're all in the saddle with this, and you know what it's like. We've thought about this a lot. That the technology of our model specifically addresses that and tries to win people over to want to be part of therapy. And let me show you a little bit about how it works and how we implement that framework. And what I find with a group like this is I'm probably not going to say anything you don't know already or anything you haven't done already. Folks like yourselves have been in the saddle maybe for years, have been challenged in so many ways. But what I think ABFT offers is a scaffold, a framework to say, work on this first. Don't get distracted by that. You're going to do that next week. Now work on this. And when I'm working on this, what is my goal? Don't get diffused. Don't say, oh, you got that, mom. You got those skills. Good. Okay, let's move on to. It's really sinking into these modules or tasks, as we call them, essential elements. They're all going to look familiar to you. You've done all of them. We're just have a framework to say, what's my pacing? How fast do I move? What do I have to accomplish here in order for the here to be set up and go well? We do a lot of preparation. The whole model is built on preparation for family conversations. So rather than putting everybody in the room together like the old days of Mnuchin, if anybody, I'm dating myself, some of us don't even know the name probably. But he used to just stick them in the room, and his charismatic Argentinian Jewish way would rally them and challenge them. And we're not Minuchins. We don't, they don't, doesn't work for us. Move a few chairs and, you think everything's supposed to go well and it doesn't. So we do a lot of preparation, meet alone with the kid, meet alone with the parent for a couple of weeks, work on very particular elements, tasks, skills, and then bring them back together when we feel they're ready to have the kind of intense trauma focused conversation that we want to get to rather than arguing about school behavior or getting up in the morning. So here's how it works. Here's how the model works. Conflicts of interest. Myself and Suzanne have really led the work. Gary Diamond, if you heard his name, he's also a core team member and has adopted a lot of our work actually for working with the LGBTQ population. But we used to get a lot of grants from NIH and American Suicide Foundation. We have a book, we get some royalties, and now we've left the university and have a training center that, supports us. Oh, so here's the three developers of the work, myself, Gary, and Suzanne, really been working since 2008, 2005, developing these ideas, testing these ideas. As I said, Gary now in Israel has really applied this work systematically, has a new book out on working with LGBTQ adolescents and young adults who, 28-year-old person in medical school now wants to get married, now wants his mom to come to the wedding. And they come to Gary and say, you got to help me resolve the division that's happened between us. I miss my mom. I want to go home for dinner on Shabbos there in Israel. But I want to bring my partner. And Gary's been in that zone using the technology, if you will, of our model to help those people resolve things. So he's done great work. Suzanne is really running the training center and is a brilliant trainer and works closely with me. We have climbed the mountain of empirical support. We're listed as an empirically supported treatment on a number of websites and this and that. It is a tough mountain to climb, and hats off to those people that are in that world. It's, doing clinical trials work is not easy. Takes 2 years to get the grant, takes 5 years to do the grant, takes 2 years to publish the grant. So every 10 years, you're lucky to have some work come out. But we've accomplished that, and it's given us the credibility to be adopted internationally on a lot of places. What's our theoretical foundation? We use attachment theory, which I'm sure all of you know. I'm not here to teach that. But we don't use attachment theory as a general idea. Oh, wouldn't it be nice if parents provided a more secure base and, could be more attuned or more mentalized their kid? It is the core clinical guidance of what we do. We are specifically focused on resolving attachment ruptures. If attachment failure leads to kids, you believe in attachment theory, leads to kids sort of tying themselves in psychological knots to protect themselves. I'm going to become disengaged or anxious, and that the environment shapes my internal world. That's the beauty of Bowlby. It's how I'm treated in the world impacts how I feel about myself. And then how I feel about myself impacts how I behave in the world. And there's actually an ongoing interaction between the between of people and the within of people. That's the way we think about it. Sue Johnson used to talk that way. And in our work, both of those are our targets. In the old family therapy world, they didn't believe in an internal psychology world. It was just kind of a behavioral change the way they act around a mealtime and the anorexia will go away. Our work, there's a lot to say about family therapy, but we think about both. We think about the psychology of kids and parents, and we think about how they interact together. And both of those domains are a big focus of our clinical work. So, what do we know? The basics of attachment. When kids experience parents as available and responsive and attuned to their emotional needs, they feel more confident. They feel parents love and protect them. They feel worthy of love and protection. This is your basic attachment framework. I think you all know those internalized working models of what to expect in relationships become models as I move into adulthood. I was treated poorly as a kid. Good chance I'm going to choose partners that treat me poorly as an adult. It's what I'm familiar with. It's what I feel I deserve. And so that early child rearing influences who we are. For Bowlby, though, what we like about him, he says the internal models are always up for revision. They're not stable like Freud suggested. For Freud, by the time you're 5, it's set in stone. Nothing's going to change. You got to learn to live with it. I might be paraphrasing him a little bit, but that's how I remember my readings in graduate school. For Bowlby, he comes along and says, because the internal world is shaped by the external world, if the external world improved, it could start to revise the internal working model. Now, we all believe the internal working models could be revised because we wouldn't be therapists. We believe I can do therapy and I can help them come to terms with or learn some coping skills, do some intrapsychic work, and revise who they are. Earn security is how the attachment world talked about it. I could come to terms with what my mother did or didn't do for me and not be controlled by it anymore, but understand it better. Attachment theory also sort of there's been a lot of work in the emotional processing world. And a lot of people think that the attachment context is where we learn a lot of our emotion regulation skills. Because I get upset, I fall off my bike, I run to my mom, she picks me up, she rubs my kepi, I calm down, I down regulate, I slide off her lap, and I go back to play. And that repeated activity of down regulating myself, self-soothing myself becomes also internalized, and I'm more able to manage my emotions as I get older. We all know what happens when parental attunement doesn't work, when it's not available. When I run up the stoop after falling off my bike and I come up, mommy, mommy, and she says, oh, stop crying. Just go in the bathroom and wash it off. And there's this sort of dismissive parental response that kids start to have a lower expectation of parents' protection. I'm not going to mom next time I fall off my bike because she's not going to do anything. In fact, she's going to make me feel bad about it because I was scared or I cried. And so we develop these relational strategies. That's how I like to think about the attachment categories to protect myself, avoiding anxious, disorganized, which I know you all, know some of that. We also know that there can be a number of risk factors that can affect attachment security, life events, family illness, parental death, loss of a parent, loss of a grandparent. These are all can be quite traumatic events and how we cope with them. And the data actually is stronger to show that you can have a secure attachment, then experience trauma and develop an insecure attachment. become less confident that the world will be a good place. There's less data on whether you can have an insecure attachment and through an improvement in the environment, I can develop a more secure attachment. Theoretically, Bowlby believed in it, Mary Main believed in it, but there's not as much research on it. It's harder to track. We think about trauma in the family with a big T, abuse, neglect, abandonment, uh, things we all see too often in our practice. But we also think about trauma with a little t, high conflict, low warmth, high expectation, low support. And that family environments, we see it all the time. Parents can be strict and rigid and argumentative, and maybe because of some of their own psychological functioning. So we don't have to have a, we think about both big T and little t as domains that we need to focus on. Now, we all know, and I don't know where you guys stand on how much you're working with adolescents or young adults, or whether you're focused more on younger kids, but we know adolescence is a very active time. Some of us just love working with those kids. Some of us hate working with those kids. But there's a lot of developmental processes going on. The old mythology of adolescent development was that the central task of adolescence was separation and individuation. You remember your Erik Erikson stages of life, that was the psychoanalytic thinking. The sooner you could get away from your parents, the sooner you could start to grow up. And I don't know how many of you, believe that. I moved across country at a certain point thinking, finally, I'm done with my mom. And I got to my hotel room, opened my suitcase, and damn if she wasn't in there, came with me. So the current thinking, both in the developmental world and certainly in the attachment world, that the central task of adolescence, a central argument in therapy, is that kids need to stay attached. And that if I can stay attached and build some autonomy and independence, but be able to return to my secure base when I needed it, just like as a kid, those are the kids that do the best in life. Those kids do better in school, do better with peers, do better with health problems. There's going to be conflict. We know that, but can I stay connected and still be independent? Can I express discontent or anger and still feel like my parents are going to love me? They're not going to abandon me just because I didn't like what they did or something like that. So for us, and this is a conversation directly in the therapy room. Mom, your kid needs you. Needs me? He's 16. He has no interest in talking to me. And we say nothing could be further from the truth. Underneath his bravado, underneath his anger, buried under his depression, he's desperate to feel connected. We all are. It's a human instinct. And here's where we use attachment theory again, that believes in not only the instinct of attachment, kids' desire to activated need for protection and love, but parents have an instinct to care for their kids. There's a caregiving instinct. My kid's falling off the bike. I'm sitting on the stoop. My kid starts falling off the bike. I drop my iced tea. I'm down the street and I catch him before he hits the ground. I didn't think about it. I didn't say, he's going to get hurt. Should I go catch him? No, it's an instinctual mama bear kind of thing for Bowlby. And we are trying to use that in therapy. We're trying to activate that caregiving love and instinct. And our main message to the parents is Mom, you're not the problem. You're the medicine. You are going to be what saves this kid. He is adrift. He's floating in outer space. And if you don't grab that rope and tether him back to earth and pull him back in, he's going to be lost. And you're one of the only people that can do that for him. So there's a lot of building up of parental competency and strength, even in the face of a parent that's got a lot of problems. We sort of try to pull away the failures, pull away the lack of confidence, pull away the frustration, and say, I know you want to be a good parent to this kid. I know you love this. I'm done. I'm done. Mom, I don't believe that. You love this kid. I see it. I see you coming here to this therapy. 7 o'clock at night, you're driving them across town and coming here because you love this kid. And we are using love talk and parental competency talk as one of our main levers, one of our main motivators to help parents stay engaged in the therapy. So how does it all, that's just a nice theory. You're sitting there saying, yeah, guy, that's pretty sure, but how do you do it? And for us, because we're in these clinical trial worlds, we're doing it in 16 weeks. This isn't a year-long therapy. We didn't have time. NIH said, you show me the outcomes by week 16 or we're not funding you again. As with all the models, CBT, DBT, everything got truncated to short-term treatment. So how did we develop a protocol that would allow us to get to core attachment traumas, allow us to build alliance quickly, and engage parents around trying to repair attachment ruptures, not school attendance. We work with a residential facility, Newport Health Academy, quite good. I think they do a good job. And we tell parents in this environment, you are on behavior management holiday. You don't have to get them up in the morning. We do that. You don't have to get them to take a shower. We do that. All you got to do is come here and figure out why you two don't love each other anymore. So the residential environment really gives us that freedom, but we frame it the same in outpatient. Look, I had cases where the kid hadn't gone to school for 4 months. He was already destined to go to summer school. And they would fight every morning. You get up, you rotten kid. Oh, mom, I hate you guys. And we said to them, and this is not what we always say, but I said to the mom, look, for the next month, just keep him home. Let's take that argument off the table. He's going to stay home anyway. He wins every day. Let's take that off the table and come see me twice a week. So we tried to get out of the power struggle around raising adolescents. Power struggles are the kiss of death in trying to rally and promote health in an adolescent. So we think a lot about how to sidestep that. So what is the model? Because we do have a formula and a secret sauce. One is it's brief, which adolescents like. Oh, you mean it's only a couple months? It's not a year and a half or forever till you decide I'm done? No, we're going to work for 12 weeks, 16 weeks. If we need more, we'll do more. But my goal is to get something done quickly. It also makes therapists work harder. Every session counts. Every phone call counts. I can't spend a session talking about the prom. I got to really, what do I want to accomplish today? How is this going to move it forward? We've developed most of the work around depression and suicide. Our grants have been that, but we have expanded to a variety of disorders, eating disorder, trauma, OCD. We have a new paper coming out on OCD work. And so the model is transportable, transdiagnostic. We've done a lot of our work with low income minority families in Philadelphia. It's where the work grew up. Um, so we've learned a lot about how, working with those communities, both low income communities as well as minority communities. There's really sometimes we blur those things together. There are SES challenges that families face, and then there's cultural things to think about that are valuable in working with families. The secret element of the model is that we've distilled the work down to 5 distinct tasks. We call them tasks. Tasks aren't things, they're not sessions, they're problems in therapy that I need to solve. Getting the parents and kid to be willing to be part of therapy. Task one. Building an alliance with the adolescent and the parent separately. Task two. Bringing them together to have a conversation about important things. It's actually task four. But it just this is the scaffold, gives a structure and a sequencing of what should I be focused on? Where am I at? How well am I accomplishing my goal? The model is manual, focused, but flexible. It's not a curriculum. It's not week 7, you pull out this worksheet and do this. It's a principle-based model. It takes you have to apply and adapt, but it gives you some focus and goals and outcomes. The thing we like about the task is it gives therapists a little more intentionality. When you're working with a family and anybody, it's easy to get pulled in multiple directions. You're trying to talk about, you know, homework, and then she's, yeah, but I can't get him up in the morning. Oh, we better talk about getting him up in the morning then. We get pulled around by the crisis of the week. And the task says, I understand that's a serious thing, but let's just finish this other piece today. Let's focus on homework, for instance. So it helps them be a little more focused, gives them some sense of where am I at? Where am I going? What first session? It's the problem I mentioned before. I'll drop Johnny off at 3 and I'll pick him up at 4. And we want to say, there's something here for you. You can help me, I can help you. So the goal of this session is to shift the therapeutic, we're running through 20 years of research in an hour, so I'm giving you the highlights. The goal of the session is to shift the focus of therapy from patient as the problem to family relationships as the medicine. We say to a kid, we do a good assessment. We get releases to talk to the psychiatrist. We do all that work. We're a multimodal approach. But at the core of the work, we say to the kid in the first session, 40 minutes in, when you're feeling like you want to die and you're sitting in your room thinking of taking pills and your parents are downstairs, why don't you go to them for help? Why is the attachment switch off? That you don't see them as a resource to help you cope with your depression, your breakup with your boyfriend, your loss of your grandmother. And try to get at some of the conflicts and ruptures that have led to this. And often what comes out is divorce and, parental depression. You're so depressed, I can't count on you. Your dad and you fight all the time. I'm afraid to get involved. I mean, kids have things to say of why they don't trust their parents anymore. And as the cusp of that conversation, your ears are, at what point is the parent going to feel criticized or threatened or blamed? What are you saying? I caused you to be depressed? So we sort of try to turn a corner at that point. We need enough trauma in the room to say things aren't going well. But we come in not around mom's anger or failure, but her disappointment and sadness. Must break your heart that he didn't come to you. You must have been terrified. This is the emotion focus work. We go after softer emotions. We don't say, how angry were you? Or I know what do you want to say to Johnny? Do you want to defend yourself? We don't elicit that response. We elicit, I know this is hard, and I know there was a bigger story here, but I can't help but think you were scared your kid might die. This is my suicide world. And it must break your heart that you and he don't feel connected anymore. Because I see what a committed mother you are, what a loving parent you are. And to feel like we've drifted, it's not what you hoped for your family. And we try to amplify longing for connection because we shape the conversation. If we let them go and do their own thing, the kid would complain and the parent would become defensive and the kid would give up. See, I told you she doesn't listen. And well, it's all, and they would do what they normally do. And instead we are, well, hold on, hold on. What interests me is that you two love each other and it's tragic that you're not very connected anymore. That's what worries me. And if you're not connected, then you're not a good team and you can't solve these problems because your kid doesn't trust you and you feel frustrated. And so we amplify longing. And then I'm able to say, how would you like it if this therapy focused on repairing the connection between you guys? I know school's a problem and I know the substance use is a problem. And, we'll get to that. But I'm interested in initially helping figure out why there's so much distrust between the two of you. Kids love it because the adolescent says, finally, someone's not just blaming me for what's going on. I'm not the only problem. My parents have been fighting for years and no one's ever said anything about that. Parents like it because they feel like, it's kind of a refreshing approach. Usually therapists have me doing star charts and behavior management and, you know, trying to, and we're saying, no, we're letting all that go. Let him wear the clothes he wants to wear. Let's stop fighting about clothes. He wants to dye his hair purple, let him dye his hair purple. If you guys felt more connected, he would become more of who he needs to be. And he'll stop having purple hair, although having purple hair could be cool. And maybe that's the better. Some kids used to you want them to have purple hair. You want them to be. This conversation all happens in our first session where we try to say, could we work on relationship improvement? We then separate them. We meet alone with the adolescent and alone with the kid. We call it an alliance task, but it's really much more complicated than that. It's really about trying to, if anybody here knows the AAI, I don't know if you have any from graduate school, if anybody did the AAI, but the concept is, do I have a coherent attachment narrative or an incoherent? When I do the AAI, do I talk too much? Do I idealize an angry parent? Do I not give enough detail? Or can I tell us honest story about who my mom was and how it affected me and its impact? I've come to terms with who they were. I now see my parent differently. I can do perspective taking rather than just feeling like, I got to protect myself. So we're interested in helping them have a more coherent attachment narrative. And that could be a session or two. And the only reason we can do that is that's the focus, that's the intention of the session. It's not, oh, let's talk a little bit about your mom and then let's talk about your girlfriend and then it's tell me about, no, no, hold on. We'll get to your girlfriend next week. Tell me the worst episode. Tell me the night dad left. It's a whole kind of technology around episodic memories and uncovering narrative and uncovering emotions. Because most kids come to therapy, oh, I don't care. I don't care if my mom comes to graduation. I don't need her anymore. And we know that if we can get underneath that, there's a story of neglect, a story of disappointment, a story of feeling abandoned. And that's where the technology of our work has a little bit of emotion focused kind of therapy approach, similar sort of work. And then we say, we think you should talk to your mom about this. That not only is it important to do the internal work, but we think you should stand up for yourself, have a voice, and tell your mom how you feel with the hope of changing the way they interact together, changing the ongoing relationship dynamic. We then meet alone with the parents, 1, 2, 3 sessions. And this is a interesting sort of sequence of events. I'm running out of time, so I'm going a little quicker. We start with current stressors. I'm here to talk about Johnny, not myself. I know, but you're so important. And I just want to know a little bit more about you. How's work? How's your health? How's your marriage going? What's it like raising your 6-year-old who has autism? And trying to lean into current stressors so that parents actually feel, wow, nobody's ever asked me about me. They're always, it's the kid and what should I do and how do I, but this guy's really interested in who I am and what's going on in our life. We do some intergenerational work. When you were a kid and you were watching your parents fight, who did you go to? It's really the AAI question. When you were scared and had an emotional need, who did you go to for help? And unfortunately, for most of our parents, um, they couldn't go to their parents. They grew up in homes that were just as chaotic and troubled. But we use that as leverage. I can't go into all the details of it, but the ultimate linking we talk about is how would you like to, after the arc of this, we spend a whole session on this intergenerational. We don't rush through it and try to draw conclusions. We explore it, we uncover it, we deepen the emotions. And at the end of that, we say, how would you like to be for your kid now what your mother never was for you? That's our sort of default phrase. You have to modify it based on the case, but that's a very common sequence of how we come out of this parent session, and offer them a chance to be now, right now. And here's the behaviorist in me. Parents say, oh, what's the difference? I can't change anything now. And we say, we don't believe that. I can teach you some skills. I can create an experience. We're gonna create an event where you and your son actually talk about the things that you've avoided for so long. And we're looking for yes, trying to get a parent to say, all right, I'll try it. We then bring them back together, and uh, kids identified conflicts, disappointments, trauma, dad's drinking, mom's depression, grandma's death. And we've gotten the parent, as you all do, okay, I'm going to be an emotion focused, attachment promoting parent. I'm going to be for him what I haven't been for years. When he ran up the stoop and wanted my comfort, I'm going to be there for him. And the kid comes and says, well, mom, I've been mad at you ever since the divorce. And instead of the mom saying, I don't know how you miss your father. He was so horrible to me. And how you, the parent says, I've never asked you how you feel about it. I've been so preoccupied with my own recovery. I haven't paid any attention. This must have been horrible for you. Tell me more. What do you remember? What do you miss? How does that feel? And we're trying to engineer an experience between them that is more attachment focused. And as likely many of you are CBT oriented people, I explained this the other day. This is an exposure exercise. That's really how we think. It's one way to think about it. I'm going to help you trust that your mom will listen and tell the truth. And I'm going to help mom have an experience of being there for their kid. And I'm going to hold them there for 3 or 4 sessions till they start to feel like, oh, this isn't so bad. This isn't as hard as I thought. My head didn't blow up. My mom didn't die when I told her the truth. And that they actually find they can work through some difficult experiences and feel closer afterwards. A lot to take in, I know. Let me show you a little video clip of task 1, just to kind of get the feel of how. What's my video? All right, do you guys see the beginning of the tape?
Yes.
Let me know if you get sound.
So here you are, James, feeling all alone.
Sound?
Yep.
Here we go. This is a 7-minute training tape. These are actors. These are based on real cases. But we made it 7 minutes long. In real life, this would probably be a 20-minute conversation. But we're trying, as a teaching tool, we tried to condense what are the key elements, the key intervention moves that the therapist uses to accomplish the reframe. And this comes about 40 minutes into the session. We've done some joining with the family. We've done a whole psychosocial problem definition. Tell me about the suicide. Tell me about the hospital. Tell me about outpatient therapy. Who's your doctors? Tell me about school. And we've done all that intake work that anybody would do. And then 40 minutes in, Suzanne starts to shift to the reframe, to the relational focus of the therapy.
Worthless, sometimes even hopeless, and maybe using the drugs a little bit to numb that pain. I'm wondering, when you are in all that pain and struggling at school and all these things are happening, why don't you go into your parents for help?
I feel like they really just don't get me.
Tell me more about that.
We were moving, they waited like a few months or something to let me know, and by then it was too late to tell half of my friends goodbye because they were already on vacation.
Yeah, so you feel like they don't get you around the move, and it sounds like maybe even since then, when you've been struggling with things, do you also feel like they haven't gotten you, that they don't understand what you're going through? So it's almost that you can't even maybe trust that they're going to be able to help you if they don't understand what you're dealing with. Would you say that's the case?
Yeah.
How about for you guys, Jennifer? What do you think about what James is saying about not understanding them?
Well, I want to understand him. I admit I don't understand the drugs, but I want to understand him. But he doesn't talk to me like he used to.
Yeah. So you really have that desire to understand and know what's going on, but there's something happening here that he won't come to you.
Yeah, we used to be close, but not anymore. He won't spend time with me. He won't talk to me.
How about you, Henry? What do you think about James saying that he hasn't come to you because he feels like you don't understand him?
I'm right. I don't understand him, man. I worked hard to provide a good life for him, and certainly a better life than I had growing up. Yeah. I mean, yeah, I don't understand why he's upset.
And I can get that. You really worked hard to provide a really good life for your family.
The boys do miss you. You know, we talk about you getting to, go to more games and do more things with them, and you just never seem to make time on your schedule.
Yeah. So it sounds like there's, Mom, that you're saying that there is a lot of space where Dad isn't able to be there. Is that how it feels like for you, James?
Yeah.
Yeah. So then you had to sit with all that pain alone. And I wonder, you said you kind of felt lonely in school and out in the world because you were having difficulty making friends. I also wonder if you were feeling lonely at home. So on top of it all, you're feeling lonely in the house too. And that's just adding to your pain.
Yeah, I mean, I really feel like I can't go talk to them about anything.
Mom, I saw you shaking your head. What's that like for you to hear?
It just breaks my heart. I feel like I failed as a mother. I don't want him to be sad. I want him to be happy and have a good life, and that's what we were trying to do.
Yeah. You really love your son.
I do.
I'm wondering, for you, Henry, what is it like for you to know that kind of James is feeling all alone? Part of the reason because he can't come to you.
I mean, I've always thought I was a pretty good father, certainly a good provider. But I don't know, maybe I'm not as good a caregiver, or whatever you call it.
Wow, that's really a hard thing to do, and a really brave thing to do. I'm wondering, James, what is that like for you to hear your father say that maybe he's not the best caregiver?
I mean, I've never heard him admit that before. I mean, it's not like that I ever said that you were like a bad father, or that, you didn't take care of us.
I mean, I'm not Superman, I mean, I've had my doubts about this move as well,
So for you, Henry, you really, you're not sure everything was right, but it's clear, I guess what I hear from there is you really love your son. But I also, I see, it seems like, James, you don't really know your dad that well.
I mean, I thought I did, but I guess not.
And I also really, the way you just defended your dad here, I also, even though you're really angry with both of them and what's happened, I feel how much you actually love your dad too. And maybe even admire him.
I do.
You know. But there's been such a disconnect between you guys. And I'm wondering if, do you want your son to know you better and to know your son better?
Of course I would, yeah.
Can you tell him that?
You know I love you, James, right? You're my son. I want to know you better.
What's that like to hear from your dad?
I mean, it's nice to hear.
Do you want to know your dad better too?
Yeah.
And have him know you better? And what's that like for you to see that?
It's what I've longed for. I mean, I know they love each other, but they just never seem to be able to connect.
And it seems like everybody in this family has really been disconnected for the past year. And that's really what I want to help you guys with. I want to, I know there's a lot to work on. There's a lot of school issues and there's the drug issues, but I really see that this disconnection is really our first obstacle to tackle. That this disconnection is really preventing you guys from being able to help James, and James, you being able to go to them for help. In order for James to get better, the first thing we need to work on is getting you guys connected again, helping you guys know each other and reconnecting you. Is that something that you guys can agree to?
Oh, for me, absolutely.
How about you, Henry?
Well, I mean, if you think this is the right way to go, then yeah, of course.
And how about you, James?
Yeah.
That's wonderful to hear. I know that if we can get all of you guys connected again, which we will, that we're going to help get James feeling better and addressing all of the concerns that all of you guys have.
So this is a quick walk through ABFT. There's a lot more detail to help guide the process, think about process. We're interested in therapists being thinking therapists. So there's a lot of principles and guidelines and things to consider, but at the end of the day, it is up to you. This is a high art therapy, and you're in the room getting close to people. And so there's a nice mix of model and therapist artistry. If you're interested in hearing more about the work, you can come to our website, ABFT International, and learn about trainings that we offer, materials, lectures, workshops, and be happy to, have you be interested in the work. If you had any specific questions and wanted to reach out to me directly, that's fine too, and I'd be happy to chat with you about what you saw today. Because we're done, right, Jen? We gotta. So I
Yes,
don't have any more time.
we are just about at time. We really appreciate everybody being here and joining us today. Thank you so much, Dr. Diamond, for sharing all of your knowledge and work with us. I'm sure a lot of people have to hop off. You did have one question in the chat. I don't know if you have a minute to.
I do, yeah.
Okay, so Rick asked, have you considered doing what you do in the adolescent only and parent only sessions conjointly, where, for instance, you ask the adolescent to just observe and listen for now, but then witness the intergenerational work that you're doing with the parent? Couldn't this have a powerful impact on the team's capacity to develop compassion?
Yeah, very interesting question. It's a funny thing. We mostly work with depressed, suicide, withdrawn, muzzled kids. And as a sort of psychological development, I'm interested in them developing the entitlement to speak up for themselves, to defend themselves in a more regulated way. So I'm less interested in task 2 and 3 about them perspective taking and trying to understand their parents differently. And they're usually too focused on their parents' needs anyway.
Mm-hmm.
So task 4 is an intensive, I'm here for you. And after some of that gets nailed and, belief in that capacity, then there's more time where mom might say, I've never told you this, but I grew up in a an abusive house. And the kid says, well, what do you mean? And that on the back side of 4, we might do more parent disclosure about themselves. So it's just a timing issue of how we think about it. The question that comes up more often is when you have 2 parents and you're doing this intergenerational work, do you have mom and dad or mom and co-parent together? And that's all kinds of clinical decisions on, would it go well? Ideally, it would be great, have dad observe mom or vice versa. But sometimes that's not, you're not going to get as deep as you'd like to with the judgmental, critical parent in the room. So it's just all kinds of clinical decisions to make around how to share that experience together. But it's a great question, and how to use those experiences to facilitate more intimacy and more knowing each other and more ability to mentalize each other. I'm really interested in the parent improving their mentalization of the kid. This is typically what we see, that parents with troubled kids come in and they're more preoccupied with their own needs and can't really imagine the kid's inner world, mentalizing it. So I'm trying to strengthen that skill, which is the inherent attachment context. And what we find is, as kids, and this is what the literature argues, as kids feel a more secure base, they're psychologically more free to mentalize other people. They're not preoccupied with defending and guarding and tied in a pretzel. And as they feel safer, it's easier for them to say, hey, when I come home late, it really upsets my mom. And I don't want to do that. I know she's working hard. And so we hope that the kid's capacity to mentalize evolves out of repairing the insecure base. That's how we think about it. What the theory would suggest. Good question. Are there other? I have time, so if there's other questions or anybody wants to ask anything.
I didn't see any other questions in the chat. I'm not sure if anybody else who is still here wanted to ask anything. Terry, I noticed that you unmuted. I'm not sure if you had something you wanted to ask. No. Okay.
He froze up.
All right.
Ooh, it's a lot to get in an hour.
Yeah, that's right. It is very tough. Well, one person we did just get a question. Do you have suggestions for using ABFT for adult families?
Yeah, it's great. In my private practice, a third of them are 40-year-old kids who come and say, my dad's 75. I don't want him to die and have these unresolved issues. It's one way it shows up. Mm-hmm. Could we do work with him so that we could work through some of the knots of our relationship so that the last 10 years of our lives together could be more rewarding? And we absolutely do that. We do very similar kind of pacing. Maybe we don't do a task 1. Maybe we don't get them together and win them, because they're sort of there as they want to improve things. So we go right to task 2 and 3, try to get to know them, develop their narratives about what they try to understand about each other and what their needs are, and then bring them back together and help them talk about the things they've never talked about. So absolutely, it's really rewarding work. And it's very different, with an adolescent, they're going home with these parents and they're still under the control of the parents. So it's a little more complex thing. You working with adults, they get to say what they want and then they go to their own lives and a little more freedom.
And you got one more question from Rick. How would you distinguish ABFT from EFT for families? I don't know if you saw that.
Yeah, I was on a panel recently. We published a paper of the 4 big attachment models, Dan Hughes, EFFT. There's really now 2 EFFT models. one from Sue Johnson's lab, one from Les Greenberg, and myself. And, we're all going after very similar things. We're all interested in repairing attachment. I think we do a little more in vivo work to try to change relationships in the room in front of me. Mom, slow down a little bit. Remember what we said in task 3 that you were going to try to be, more patient and listen more? Yeah, I remember. All right, give it a try. And I'm shaping in a behavioral way positive interactions. So I think we're doing some similar work, not to brag, but I do think people think our work is a little easier to learn because we have operationalized so many pieces that it's a little more systematic that people say, someone said to me once, I go to a Dan Hughes workshop, sure many of you know him, and I'm totally blown away, his impressed work. But to do Dan Hughes's model, I have to be Dan Hughes. And I'm not Dan Hughes. Whereas your model, I can be myself and I can use these skills to facilitate pretty profound emotional conversations. So it's, one way to think about it. But, they're great work, the AFT model. I mean, how could you not but admire that whole line of work? And I was very influenced by Les Greenberg in my early years and did my dissertation with him. And so his imprint is on me. It is interesting since people are staying. Our colleague, Gary Diamond, this is great. He did a study with adults, young adults, unresolved business with their parents, randomized them to ABFT or the EFT 2-chair strategy and in vivo talking to my parents. So in both therapies, they're talking to their parents, and any of you that have done 2-chair, it can get pretty powerful and emotional, and both treatments reduce depression and anxiety equally. But the ABFT model improved current attachment security. So there was the real relationships changed, not just the in vivo working through, I now go home for dinner on Sunday night and my dad doesn't yell at me as I walk in the door. He's learned how much that. So we've changed the between of people, not just the within of people. It's a little more individual versus family work, but it's anyway, it's another way to think about the work. Rick, you look like you have a question there. You're sitting there with penetrating me. You're on mute.
Thank you. I asked 2 questions already, and you've done
okay.
a lovely job in addressing them both. So thank you.
I did feel that then.
Yeah, thank you for your questions, Rick. Thank you to all of you who have remained on. Thank you again to you, Dr. Diamond. This has been really helpful. And for anyone who's still here, joined us late, we will be sending out the video from today. So you will have that. Thanks so much. We really appreciate it.
Thanks for having me.
Take care.